Imagine this. A 52-year-old named Maria goes home after a routine abdominal surgery. On day 3, she notices a little redness at the incision edge. She shrugs it off, calls a friend instead of her surgical clinic, and by day 6, she's back in the ER with a spreading infection that could have been treated outpatient. I want you to picture Maria, not to scare you, but to sharpen the question we'll answer today. What should you actually do in the first 2 weeks after surgery to stay HACE? Let's start with a quick safety note. This episode is educational, not a replacement for your surgeon's instructions. If anything I describe doesn't match your discharge plan, follow your team and call them with the scripts I give you. Let's separate medical fact from fiction and keep readmissions out of your story.
Hi, I'm Nurse Jessie. Today, I'll walk you through a conservative, practical 2-week recovery roadmap for common surgeries, ambulatory, short inpatient stays, orthopedic, general, and gynecologic procedures. I'll tell you what to do in the first hours, how to manage dressings and drains, safe pain strategies, bowel and bladder basics, mobility and DVT prevention, and exact red flags that mean call now. There's a downloadable 2-week checklist and phone scripts linked in the episode notes. Grab that. It'll make things so much simpler. Ready? Let's go. First hours at home, you should have a plan before you roll through your front door. Arrange a comfortable chair or bed with pillows to support the incision area, a small table nearby for water and medications, and a trash bag for used dressings. Verify your discharge instructions right away. Med names and doses, follow-up appointment date, and any wound or drain instructions. If something on the sheet looks different from what the nurse told you, call the clinic now. For pain control, set a simple plan. Take your scheduled non-opioid medication, acetaminophen or ibuprofen, unless advised otherwise, and use your opioid only for breakthrough pain and at the lowest effective dose. Write alarm times on your phone so you don't miss doses that help you move and breathe comfortably. Wound basics can feel technical, but I'll make it plain. There are common dressing types: transparent film, gauze with tape, and pre-packed dressing kits. If you were told to keep a dressing clean and dry, do that. Don't open it unnecessarily. When you do change it, wash your hands, remove the old dressing gently, and inspect the incision. Look for wide separation, increasing redness, heavy swelling, pus, or a foul smell. It's helpful to take a photo each time you check the wound and timestamp it on your phone. Place a coin or a small ruler in the photo so your clinician can judge size. If the dressing needs a replacement and you're unsure, use a clean gauze and tape temporarily and call for guidance rather than improvising elaborate home remedies. If you have drains or catheters, treat them conservatively. Don't tug, don't clamp unless your team told you to, and secure tubing so it won't be pulled. Track output. Note the time, the amount, and the color. For example, write down 6 p.m., 60 ml, serosanguineous in a small notebook or spreadsheet. Sudden drops in output, bright red bleeding, or thick pus-like drainage are reasons to call. If a drain accidentally comes out, press clean gauze to the site and call immediately. Don't jam it back in. For urinary catheters, keep the bag below bladder level, empty the drainage into a clean container, and report cloudy, foul urine or inability to pass urine after catheter removal.
Pain management. This is where many people get stuck. Think multimodal. Scheduled acetaminophen and, if allowed, NSAIDs like ibuprofen. Reduce inflammation and opioid needs. Use ice for the first 48 hours if your surgeon said it's okay, and elevation when possible. If you were given an opioid prescription, use it at the lowest effective dose and for the shortest time necessary. Never mix opioids with alcohol, benzodiazepines, or other sedatives. Watch for signs of oversedation, slow or shallow breathing, inability to stay awake, or confusion. Those are urgent. If you need to ask for more pain meds, call with a focused script. 1 line. I'm X, had surgery on Y date. My pain is X out of 10 despite current meds. 2 line. My name is X. My incision pain is 8-10. Meds taken were A and B at time C. Can you advise next steps? That gives clinicians the exact information they need to help.
Bowel and bladder issues are common after surgery, especially with opioids. Prevent constipation proactively. Start a stool softener like Docusate the day you go home if your team recommends it, and add a mild osmotic laxative like polyethylene glycol if you haven't had a bowel movement in 48 hours after starting opioids. Hydration matters. Aim for clear urine and regular sips each hour when awake. If you cannot urinate at all after catheter removal or you're straining excessively, that's urgent and needs evaluation. And be cautious mixing bananas, dairy, and low-fiber habits with opioids. Small diet adjustments and movement help a lot.
Mobility and DVT prevention. Get moving early, but do it safely. Start with short walks in the room or hallway several times a day. Walk to the mailbox if you're able. For stairs, use an assistive handrail and take a rest between flights. Do ankle pumps and calf squeezes every 30 minutes while awake to encourage circulation. Point your toes down, then up 10 to 20 times, and wiggle your feet. Watch for signs that are more than normal soreness. One calf that's suddenly swollen, painful, warm to touch, or a sudden shortness of breath. Those are red flags for clot and need urgent evaluation. If you have compression stockings prescribed, wear them as instructed.
Wound infection and fever thresholds. Let's be concrete. Call your surgical team if you have a fever of 101.3 degrees Fahrenheit, 38.5 degrees Celsius, or higher, or 2 readings over 100.4 degrees Fahrenheit, 38 degrees Celsius, taken a few hours apart. Also call for increasing redness that spreads beyond a fingertip's width from the incision, new or increasing drainage that is pus-like or foul, wound edges that separate, sudden increases in pain, or new nausea and vomiting. If you see any of those, call first. If you can, send a time-stamped photo and the time of symptom onset. If you're dizzy, fainting, rapidly breathing, or your heart feels racing and you can't calm it, go to the emergency department.
Now, exact phone scripts you can use when you call the clinic. One-line script for a simple check. Hi, this is Jane Smith. I had surgery on March 1st. My incision has new redness and pain. Can you advise? Two-line script when you're sending photos. Hi, this is Jane Smith. I'm attaching a time-stamped photo of my incision taken today at 4:30 p.m. It shows worsening redness and some drainage. My pain is 610. What should I do next? Clinicians need date of surgery, the symptom with timing, current meds, and photos with a scale. That short, factual structure gets you action quickly. Supplies and logistics matter. Organize them now so you're not scrambling. Keep an open box with spare dressings, clean gauze, tape, gloves, a small notebook for drain outputs, and printed discharge instructions. Refill prescriptions early. Many pharmacies need 24 hours to process prior authorizations. If your surgery team offers home health or a visiting nurse and you're higher risk, elderly, mobility limited, or with complex strains, ask for that visit before discharge. Document everything. Times you changed dressings, photos, when meds were taken. That log is gold if a clinician asks for a timeline. Caregiver roles and boundaries. If someone's helping you, give them clear tasks. Dressing changes, med administration times, mobility assistance, and the phone scripts to call with. Avoid unsafe shortcuts like using household adhesives on wounds or applying unapproved ointments. Caregivers should also keep consent and legal boundaries in mind. Don't sign forms or make decisions without the patient's direction unless previously authorized. If family members feel overwhelmed, schedule a check-in call with the surgical clinic to review instructions together. Clinicians can often clarify and ease that burden.
3 concrete takeaways you can do tonight. 1. Create your recovery station. Water, meds, a trash bag for dressings, phone charger, and the 2-week checklist from the episode notes. 2. Set 2 reminders on your phone. 1 for scheduled non-opioid meds, and 1 for a short walk every 2 hours while awake. 3. Take an initial, time-stamped photo of your incision with a coin or ruler for size, and save it in a folder labeled Post-Op Photos. Do these tonight, and you've already reduced a lot of common risks. Before we close, a few conservative safety reminders. If you're ever in doubt, call your surgical team or seek urgent care. Don't wait to see if something gets worse. Never change medication dosing without talking to a clinician. If you have complex needs, major cancer surgery, transplant, or pediatric patients, use the checklist as a starting point, but make sure you get procedure-specific instructions and consider arranging a nurse visit at home. The downloadable checklist is modular for exactly that reason. If this episode helped you feel a little less anxious and a little more prepared, please subscribe to the show. There are more patient-centered explainers coming each month. Download the 2-week checklist and scripts from the episode notes. Use them tonight to set up your recovery station. And if you found the scripts useful, share the episode with a friend or caregiver who's preparing for surgery. Thank you for trusting me with a few minutes of your recovery prep. Be conservative. Take photos, document, and call early when in doubt. Those small steps save a lot of worry and bad outcomes. Until next time, stay informed, stay compassionate, and always put safety first.